Okay, it's my great honor to join this meeting. I'm a health economist by training, but I also work a lot on aging issues and also deeply engaged in the policymaking for long-term care insurance in Korea. So Korea introduced a long-term care insurance, is a public mandatory one, in year 2008. And before that, Korean government established about a national planning committee for long-term care. So we had about 3 or 4 years of planning. This committee consisting of various experts, government officers, policymakers, and some stakeholders. And we had a series of policy discussions, public hearings, and reports. So, and then after this planning committee, then we formally introduced the mandatory insurance for long-term care. And then we also established a so-called National Committee of Long-Term Care, which is a key policy-making committee for long-term care insurance. Next, please. Next, please. Okay, let me first examine some key features of long-term care insurance. Next, please. So when there was a question from your organizers that whether we have a series of pilot. Actually, we had a pilot but very limited scope because compared to the health insurance system, long-term care insurance is a bit simpler. I mean, because first, we already have a mandatory health insurance system for everybody. So people are very familiar with a contribution-based insurance approach. Second, compared to health insurance, the benefit package of long-term care insurance is simpler. You know, in healthcare, you can imagine how many medical services we provide. For like 100,000 of services, 100,000 of medicines, and also it depends on the physician visits or secondary level hospitals, tertiary level hospitals, very complicated benefit packages. But in long-term care insurance, it's basically labor-intensive services. We don't provide coverage for individual services because in long-term care, there are two basic benefit packages. One is visiting care for those who live in home, and other one is institutionalized care. And of course, we have some kind of respite care, but two typical cases is just that those who stay in home and those who stay in long-term care institutions. So because of that, one of the most important thing it's not like a technical issue, but it is more like a political commitment and consensus building among the general public. Okay, so Korea has a public mandatory insurance for long-term care. This is a separate from health insurance system. So when we first introduced long-term care, we had a long discussion about this, whether the new long-term care insurance should be separate from health insurance or should be a component of health insurance system. But we thought that when it is a separate, dedicated to elderly long-term care, then probably people are more willing to pay for this separate insurance mechanism. Okay? But this long-term care insurance system is managed by the same insurance agency. In other words, we have a national health insurance service. This is a single payer of health insurance similar to BPJSK. And this NHIS also manages long-term care insurance. So in other words, National Health Insurance Service in Korea manages two insurance programs. One is health insurance, the other is long-term care insurance. But they're managed by a single organization, but with different funds. But there is we still have some kind of issues about the coordination between healthcare and long-term care. I think this is very global issues, but we also face this lingering problem of how to coordinate healthcare and long-term care, because all people need both. And also there's an issue of what's the role of local government. So in Korea, this health insurance system, long-term care insurance system is a separate from local government. So in that case, we have a many kind of a local community level welfare services managed by local government. So we have another coordination problem. So this type of coordination is one of the key problems in long-term care financing and long-term care, overall long-term care system. Next, please. And population coverage, this is very important. We have two types of beneficiaries. One type is for those over 65. So for those over 65, they are eligible for very wide, like a comprehensive long-term care services as a benefit. However, there are another type of beneficiary which are younger generation, I mean the age is below 65. So these younger people, their eligibility is much more restricted. I mean, younger people, when they have age-related long-term care needs, so age-related disability, age-related long-term care needs, they can be eligible for long-term care insurance benefits, such as suppose a 40-year-old person has a Parkinson's, okay, or dementia, and then long-term care needs. In that case, he's eligible for long-term care insurance. But compared to older people, this younger generation, their eligibility for benefits is much more restricted. So that's why I'm saying it's a mixture of Germany and Japanese model. Because in Germany, there is no age limit. Because German long-term care insurance is basically a disability insurance. It covers all long-term care needs regardless of age. Japanese model is a bit similar to Korea, but they have two types of beneficiaries. One is those over 65, and another types of beneficiary is from 40 to 64. So in a sense, that's why in a sense, we Korean model is a mixture of the German, Japanese, and we in Korea, basically everybody who pays health insurance contribution, they should also pay long-term care insurance. So in other words, the younger people, I mean, younger than 65 years old, they pay contribution. I mean, even if suppose you are 625 and earns wage, then you should pay long-term care insurance, but their eligibility for long-term care benefit is very limited. So that means this is a huge intergenerational cross-subsidy, because those below 65, they pay contribution, but they know that the possibility they need long-term care benefits is very limited. So this system is based on this intergenerational cross-subsidy. So in terms of the number of beneficiaries as a percentage of those over 65, I mean, it's increasing every year. So like as of 2022, about 10% of those over 65, they get some benefits of long-term care insurance. Currently, about 20% of Korean population are over 65. Next, please. Assessment is a very important component. One of the big difference between long-term care insurance and health insurance. Because in health insurance, if you feel sick, if you feel the need for medical care, people go to physician clinics and hospitals. Okay, there is no need assessment process. But in the case of long-term care insurance, if a person think he or she needs a long-term care, they should apply for a needs assessment process. And then need assessment team from National Health Insurance Service, they visit the person at home and check and assess the physical and cognitive functioning, or disability. Okay, this is a big difference between health insurance and long-term care insurance, and it's like annual assessment and assessment committee. There's also assessment committee to finally approve this assessment results at the region level. Next, please. So these certifications mean we are in the process of revision, but in the current form, there are like 52 items. So there's like a questionnaires and tick, tick, tick. So, and originally we started with the 3-level systems and expanded incrementally into 5-level systems. So from level 1 to level 5. So level 1 is most serious, completely dependent. To level 5 is a less severe. And also about 7 years ago, we introduced another level, level 6. This is kind of cognition support. It is intended for those who have some symptoms or problems of dementia. So this assessment is a key process. This is it determines how many people are covered by long-term care insurance, who gets benefits. So this is one of the key element of long-term care insurance. Next, please. So this is that's correct. So from 2008, we first introduced. So it covered about 4% of those over 65 years old. Every year increase. And then about 2 years ago, it covers about 10% of those over 65. Because, population is aging. And more people become older than 65. So the people who gets long-term care insurance benefits are kind of rapidly increasing. Next, please. So this is a distribution of grades. So when we first introduced long-term care insurance, like 27% are in more severe, and 27% grade 2, grade 3 are about half. And then we incrementally increased the number of levels, grades. So, and then 2014, we had 2 more levels. And then, so as of 2022, about 5% of the beneficiaries are most severe grade, most severe level. And then 9.2% and 27% 45, and the grade 5 is 11. And then this is mainly for dementia patients. It accounts for about 2.3%. So this is a distribution of grades. Because as you can see, that this grade 1, this is a most severe level. So they are eligible for higher benefits compared to a lower grade. Next, please. So contribution, we started the contribution rate as like about 4% of health insurance contribution. So it's not a 4% of income, but it's a 4% of health insurance contribution. In other words, as I mentioned earlier, anybody who pays health insurance contribution, they automatically pay long-term care insurance contribution. It's a kind of clever way, clever way to collecting extra contribution. So it's linked to a health insurance contribution. And you can see every year is increasing. Contribution rate, we started like less than 5% of health insurance contribution in 2008. Most recently is about 13% of health insurance contribution. Health insurance contribution of health insurance contribution rate is about more than 6%, right? 6% of income. So 6% multiplied by 13%, like almost 0.8%. So about 1% of your income is collected or charged for long-term care insurance. In terms of financing mix, contribution rate is about 60 to 65%. Government pays subsidy for those who are poor and vulnerable. Co-payment is different for long-term care institution and home-based care beneficiaries, because we want to encourage people to stay home rather than staying in institutions. So that's why we set that the copayment for home-based care a bit lower than the copayment for long-term care institution. And there are exemptions of copayment or discount of copayment for the poor. And meals and private rooms in long-term care institutions are not covered. Next, please. So this is a fiscal status. Sorry, this red line is an annual expenditure. So this blue line is an annual revenue. Because we revise contribution rate every year. So you can see that from the beginning until 2015, we had a surplus. So, and then there's a rapid increase in expenditure, then we have a deficit. But this is an annual deficit. So total, this is a cumulated reserve. So when there is a annual deficit, cumulated surplus is decreasing. So there's a huge decline in cumulated surplus. So we rapidly increase contribution rate, and then revenue is greater than expenditure. So now we have a bit higher reserve so far. Next, please.
Pardon me, Professor. You have 10
Yeah.
minutes remaining.
Hello?
You have 10 minutes remaining. Just
Okay, sure. Okay. And then this is a long-term care expenditure by service type. So we have two types of care, institutional care and home-based care. So in half and half. But as we extend the coverage for those with less severe, less dependency, the proportion of home-based care in terms of expenditure is relatively increasing compared to the institutional care. So about 62% of total expenditure was spent on home-based care, about 38% spent on institutional care. And within home-based care, there are different types. Majority of them are home visit care. Some there are home visit bathing service, home visit nursing, day and night care. This is temporary day and night care and short-term care. And also long-term care insurance covers welfare equipment and devices. Next, please. So type of benefits, mainly service benefits. Okay? In other words, similar to health insurance system. So it's the services provided by certified long-term care provider. They are covered. And cash benefits are available, but only in exceptional cases, such as when there is no service providers in the community. But this is very exceptional. Payment to long-term care provider depends on the type. So in terms of visiting care, visiting nursing is a payment per hour. Visiting bath is a payment per visit. And institutional care, day evening care is a payment per day. So it's like a per diem payment. But there is a ceiling on the benefit coverage for non-institutional care. Next, please, I'll show you. So this is a monthly ceiling on the benefits. As I said, the benefit package in long-term care insurance is simpler than health insurance because this is just a care, labor-intensive care provided by care providers. So for home-based care, the level 1 more severe and the less severe, the more severe cases, they have a higher ceilings of benefits, right, compared to lower level. And for each same level, the ceiling is higher for care facilities because, in the long-term care facilities, the cost structures are different. So they employ more workers, and there are some depreciation, some care facilities. So ceilings of benefits is higher for care facilities, institutions compared to home. And also, as I mentioned, the higher the severity, the higher the ceiling on benefits. Next, please. Next, please. So again, this is a per diem payment. It's a bit similar structure. This is a per diem. So higher per diem payment for providers when there is a more severe cases. It's a level 1, level 3 to 5. And also the senior congregate housing is a kind of group home. So group of, all the people live together. Next, please. And governance, I think this is a very important structure because this is a health insurance, long-term care insurance system. We should make decisions on contribution, benefits, and payment. So we have a tripartite committee, representatives of payer group, provider group, and those who represent the public interest. So total number of members are like 22, 7 from payers, 7 from providers, 7 from public interest, and 1 for as chair. Chair of this committee is the Vice Minister of Health and Welfare, and one of the public interest member becomes the vice chair of the committee, and also this person is the chair of the subcommittee of the technical issues, because this National Committee on Long-Term Care is a very big committee, open to the public, media coverage. So we have some, very big decisions, but also we need some kind of subcommittee that which meet more frequently and had more deep technical discussions. So I was the chair of this subcommittee on technical discussions, and I was the vice chair of this National Committee for Long-Term Care. And this is a key governance structure. We have a very similar governance structure for national health insurance. We that have a National Committee for Health Insurance. Similarly, that is a tripartite committee. So payer group, provider group, public interest group, they all represent those each groups. Next, please. Challenges. Next, please. These are the key challenges. What should be the ideal optimum population coverage? I mean, if we cover more and more older people, it may be good for financial protection. However, the financial sustainability of funding or long-term care insurance system can be a problem. What should be the benefit package? Currently, the long-term care insurance is mainly a very labor-intensive service benefits, but how to diversify this benefit package and how to make it more responsive to all the people. So this is another challenge. And the care, sometimes the majority of these long-term care benefits are provided by care providers. Usually care providers, they get certificate after a few months of training. But they also need some kind of services provided by registered nurses, because all the people need both long-term care and health care. And we suffer from the oversupply of providers. As I mentioned, if you get only like 3 months of training, you get certificate. So many people get certificate. So, but their participation in the labor market depends on their labor compensations. And care workers is a high turnover, low pay, very difficult. So this is a big dilemma. So government want to consider the import of workers, but the current care workers, they have a huge labor union. So labor unions are opposed to any attempt to the import of workers. So care workers turnover, this is a big issue. Next, please. So this is a comparative needs assessment, which is a direct impact on population coverage. Like Germany, this is a comparison of 2010 and 2020. Germany with population aging is increasing. Okay? More and more people are covered. Japan also increasing. Korea also increasing, but Netherlands is decreasing. And it's a very important question, because in the Netherlands, because as I said, long-term care insurance, it has a boundary with health insurance and also community welfare services. So in Netherlands, they made a big policy decision such that they delegate the cases of less severe old people, care of them, they give it to local government. So this is more like a long-term care insurance population coverage. So in other words, in Netherlands, they reduced the population coverage of long-term care insurance, and instead they gave this responsibility for the care of these less severe people. They give this responsibility to local government. Okay, so it all depends on the policy decisions. To what extent it is covered by health insurance, to what extent it should be covered by local government. So this needs assessment, as I keep saying, this is a key measures. It can control the entry point. It can control the population coverage. Next, please. Long-term care providers from beginning till recently almost tripled, right? Home care providers of more than 6,000 becomes 18,000. Facility, similarly, more than 3 times increased. Because this is a private market. Korean long-term care system is a private sector dominated system. So entry barrier compared to hospitals, compared to healthcare sector, the entry of the long-term care sector is easier. And as a result, there are so many people, so many providers, so many facilities. So we are suffering from oversupply, over competition, and sometimes this over competition threatens the quality of care of long-term care. Next, please. Governance. We have a centralized long-term care insurance system because NHIS is a single payer, very similar to the single payer BPJS care. So this is very different from Japanese system and German system because Japanese and German health insurance, long-term care insurance, they have a pluralistic approach. Whereas Korea, Indonesia has a central single payer health insurance system. So in the sense, this centralized nationwide single payer long-term care insurance has the advantage of efficient risk pooling and equitable benefit packages, but we have a problem, a dilemma of how to coordinate a community-based care in the local level. Because compared to healthcare, long-term care should be more locally oriented in a sense. So, and what should be the role of this local government and how to coordinate between long-term care and welfare services? Because like meal services, transportation support, these are the typical welfare services provided by local government. So it would be much better if these community level local welfare services are well coordinated with long-term care supported by long-term care insurance. So this governance and coordination is a big issue. Next, please.
Pardon me, Professor, do you need more time?
Yeah, there's 2 or 3 more slides.
Okay, great. Thank you.
So although also another coordination is a coordination between healthcare and long-term care. Okay, because the problem is that the older people need both medical care and long-term care. How to coordinate. So if you have a good primary care, if you have a good primary care system as a good gatekeeping, you are much better. But unfortunately, in Korea, it's a private sector dominated system. So we don't have a good gatekeeping primary care. So this threatens the good coordination between healthcare and long-term care. And people choose basically, because some older people, they need both healthcare and long-term care. And how to coordinate. Next, please. So especially, we have a so-called long-term care hospitals. So these long-term care hospitals are covered by health insurance. And we have a long-term care institutions, residential care covered by long-term care insurance. Sometimes the boundary between long-term care hospitals and long-term care institutions are not very clear. In theory, it's clear, but in reality, some people want to stay in long-term care hospitals for like a 6 months, 1 year, more than 1 year. They do not want to go to long-term care institutions. So in that case, the relative generosity of benefit packages of long-term care hospitals and long-term care institutions matters. So still, we have still persistent social admissions in acute care hospitals, even after the introduction of long-term care insurance. Because we thought that once we introduce this long-term care insurance, then older people who used to stay in long-term care hospitals, they will move to long-term care institutions. But some of them do not want to move. They want to still stay in long-term care hospitals. So this social admissions is a big problem for us. So basically coordination between healthcare, long-term care, coordination between long-term care and social welfare services. Next, please. So I'm just showing that the still average length of stay in long-term care hospitals is very high. Next, please. So this is it. So as I said, the key challenge for us is how to coordinate between healthcare, long-term care, and community local services. Thank you.
is there a best practices from developing country in developing an LTC insurance that you know? And the second question is there a study in Korea?
Actually, second question, I got it because it was in English. But
Okay.
question,
The third question is how did South Korean deal with determining or measuring the demand or the need and having the efficiency of the cost, but also the developing the human resource capacity of the caregivers. That now that you can have a surplus of the service provider. And the last one is, in your opinion, for Indonesia, which is better for LTC to be administered by the BPJS Kesehatan or Health or other institution? Please, Professor.
okay, thanks a lot. First, sorry, I haven't seen any formal financing mechanism such as long-term care insurance in the case of low and middle income countries. Currently, because it's a population aging. Because when the country does not face a very serious population aging problems, people's awareness of this problem is still low. So it's not easy to persuade the general public. What I can suggest is a big social program. So it takes multiple years. In the case of Japan, Korea. In the case of Korea, as I mentioned, we have a national planning committee for 3, 4, 5 years. So this is so. What I'm suggesting is that probably for Indonesia, it's time to start discussions how to cope with these issues. So that's my suggestion. And in the case of surplus, this is not a long-term financing. It's more like a short-term financing. So as you know, surplus is determined by both revenue, contribution, and cost. Sorry, in terms of cost is ever increasing because population is aging. The proportion of those over 65 is already 20%. It used to be 10%, but already 20% is ever increasing. That means demand for healthcare, demand for long-term care by this increasing number of older people is ever increasing. So we should work very hard to reduce cost, improve efficiency, create additional fiscal space, but that is not enough. That is never enough. We keep increasing contribution. That's how we can have surplus. So there's the politics. I mean, because as I said, I'm deeply involved in the policy making. So I call it political economy of surplus. When there is a surplus, it's very difficult to increase premium contribution because labor unions, they are opposed to it. So when we have a surplus, the surplus is decreasing. And once the surplus is decreasing and no more surplus left, then it is easier for us to persuade people, okay, there's no other way to pay more. So there's a big politics or political economy of surplus in the national insurance system. That's from my own experience, not as a researcher, but as experience from policymaking. So, sorry, as I mentioned, to be honest, we work very hard, but it's not really the issue of efficiency gain, but more of a increasing revenue. But in terms of those strategy, how to make people willing to pay health insurance and long-term care insurance. Well, I've been working on health insurance system in Indonesia. I visited Bangladesh many times and Indonesia about 10 times in the past. So I know that you have a so-called missing middle problem in the health insurance system. So BPJSK, you successfully merged all the insurance schemes into one, still you did not achieve a universal coverage of population. I know you are struggling. So in the case of Korea, and also from the experience of many countries, first, there should be a political. Sorry, I talk too much about politics. I'm an economist, but this is a big social problem. Economic analysis alone can never work. We need a big social consensus and a political commitment. So first, there should be mandatory. When the health insurance, healthcare financing is not mandatory, we can never achieve universal coverage. But mandatory is not enough because it should provide some benefits for people. It's more like a pull-in strategy. So like a health insurance in the case of Korea or some countries who already achieved universal coverage, they successfully provided benefits. And people understand that I can be sick, ill next day, and with its health insurance, those benefits. The health insurance program should work hard to provide good benefits to the people, such that the people can understand it's cost beneficial for them to pay health insurance or long-term care insurance. It's like a proven strategy. But in the case of long-term care insurance, it's a bit difficult, right? Because it does not affect me, young people. They know it does not affect me. So about 20 years ago, I wrote many newspaper editorial. We persuaded the people, hey, young people, we don't need it now. But if you pay contribution, it will help your parents. Okay? So we still, at that time, young people still have this kind of a moral obligation that I should care my parents. If I cannot care my parents myself, I should pay something for my parents. And also from a efficiency argument, we should persuade the Ministry of Finance such that first, if we don't have this kind of a long-term care system, when parents need long-term care, some young people, they should sacrifice their labor. So there's a huge labor participation cost when there's no long-term care. Second, when you don't have a good long-term care system, many older people, they keep staying in acute care hospitals because acute care hospitals are covered by health insurance. If they leave acute care hospitals, no public coverage. So if we have a good long-term care system, we can cannot eliminate, but we can reduce social admissions in acute care hospitals. That's kind of efficiency argument. Two very important efficiency argument why we need long-term care system. Also, another one is the quality of care. When I talk with many people in Asia, the first response is that, well, we have a family value. We will take care of my older parents when they need. And trust me, this type of family value rapidly changing, rapidly erode, such that young generation, they do not want to provide care for themselves. They may be willing to pay, but they do not want to provide care. So even from a parent's perspective, is the quality of life good when they take care from old adults? I don't think so. Like a long time ago, we used to provide care for our children, but now we have a kindergarten. Right? It's like a socialization of childcare already done. It's a time to think about a socialization of care for our older parents. Over.
Thank you, Professor. Actually, there's one more question about what do you think, which institution in Indonesia is better to administer the?
It's a very difficult question. I mean, as I've been working, I was the chief of the health sector in ADB as well. So I've been working in many countries. This governance issue is the key. Very difficult because we know health is a health. The long-term care is falls between health sector and social sector. There is no clear answer. In the case of Japan and Korea, it's easier for us because in the case of Japan and Korea, we have a single ministry covering both health and social. But other countries, I mean, all I can say is that it all depends. It all depends in your own context. It's a very difficult question. Sorry.
Thank you, Professor. Kita beri applause.